Hi. Good evening, everyone. I'm Ankit Balani, consultant radiologist from Vijaya Diagnostic Center, Hyderabad. I welcome you all for today's Clinico Radiological webinar. This is a series that we conduct every fortnightly, and every fortnightly we would discuss topics of important clinical interest. Today's topic of discussion is understanding and imaging of acute encephalitis in children in India. We are honored to have Dr. Lokesh Lingappa with us today. He is the clinical lead of Department of Pediatric Neurosciences, Rainbow Children's Hospital, Hyderabad. Sir completed his graduation from Karnataka Medical College, Karnataka, following which he did his pediatric training from the esteemed PGIMER Chandigarh, following which he did his DM Neurology in NIMHANS, Bangalore. He has done fellowship in pediatric neurology and has done MRCPCH from UK. We welcome you, sir, for today's webinar as a chief of guest. Thank you for
Thank you.
accepting the
Thank you.
Today's speaker is Dr. Khalid. He's working with us as a consultant radiologist. He's completed his MBBS from Osmania Medical College, Hyderabad. He's done his MD in radiodiagnosis from Mamta Medical College, Khammam. He's completed his fellowship in pediatric radiology from CMC Vellore. Welcome, Dr. Khalid. He'll be the speaker for today's webinar. Before we move on to the talk by Dr. Khalid, I would request Dr. Lokesh Lingappa, sir, to briefly talk about the clinical perspectives of imaging of children with presenting with acute encephalopathy.
Yeah, actually, Dr. Ankit, I'm not going to talk anything about imaging. I'm going to
Yes,
just
sir.
give a clinician's perspective while we are referring a child for the imaging. What are the things we go through? And then Khalid can take over from there. Can we have the presentation, please? Yeah. So whenever a child presents with acute encephalopathy, next slide. So you have to wear a investigative hat to know the reason, because the etiologies are so varied. So you need to look at the anatomical basis. It comes from history most of the times, almost 80%, examination, and a tailored examination. So end organs we need to look at. We need to look at the inflammatory markers, the electrolytes, the blood pressures, the sugars. All those things have very important role in a child with acute encephalopathy. Radiology obviously plays a significant role along with the CSF and other investigations. Next slide, please. Yeah, I think it's not showing very well. So the cause of acute encephalopathy, as you know, is either a diffuse cerebral dysfunction, that's a diffuse cortical involvement, which is the most common cause in pediatric age group, or it's a raised pressure causing herniation syndromes, or a ascending reticular activating system involvement. Next slide, please. So if you look at a textbook, you look at various reasons for the acute encephalopathy. It could be infection, inflammation, autoimmune pathologies, trauma, vascular, malignancy, metabolic, toxins, hypertension, nutritional. So all these categories of disorders can give rise to a acute encephalopathy. It is for the clinician with the team of radiology, microbiology, and other allied specialties to work up the cause for the acute encephalopathy. Next slide, please. So I think Dr. Khalid must have also included this definition. Encephalitis is encephalopathy associated with altered mental status lasting more than 24 hours with fever of 38 degrees or more, seizures, focal neurological findings, CSF pleocytosis, focal EEG abnormalities, and abnormal neuroimaging. So at least one of these following should be there. So generally they have more than one of this. That will be easier for us to have a confirmed diagnosis of encephalitic process. But it is in a clinical setting, it's very difficult to differentiate between encephalitic versus encephalopathy process. So we will have to investigate overlappingly for both the etiologies. Next slide, please. So as a clinician, very good handle is how is the onset. If there is a hyperacute onset, within minutes to hours, you're looking at a vascular etiology, either ischemic or a hemorrhagic etiology. Hypertension can also present quite rapidly. Trauma, toxins. So these are the things you should look at when there is a hyperacute onset. But if it is acute onset between 1 day to 7 days, you're looking at infection like viral or bacterial are the most common. followed by inflammation, vasculitic syndromes, metabolic etiologies, including acquired metabolic etiologies like hypernatremia, hypoglycemia can also present quite acutely, and endocrine etiologies, very rarely severe hypothyroidism, can also present with acute encephalopathies. Subacute etiologies, you are looking at infection, which will be TBM, is the far most common etiology for acute encephalopathy in Indian setting, and then autoimmune etiologies, vasculitis, and malignancy rarely. Next slide, please. So the history, I think all of us are very clear that is very important part of your diagnostic armamentarium. So from relatives, from friends, from the bystanders, if it is acute onset etiology, history of headache, vertigo, focal weakness. So all these things will point towards a particular pathology. If there are seizures, initial seizures, and the child is not having seizures later on, only encephalopathic, you are looking at non-convulsive status epilepticus. And the previous medical history becomes extremely important. If there is IDDM, whether hypoglycemic, hyperglycemic coma, CKD, chronic kidney disease, either associated with the uricemia, hyperuremia causing the coma, or your electrolyte disturbances or hypertension. So you'll have various differential diagnoses within the given etiology. Chemotherapy related pathologies like your methotrexate induced toxicities, or other infections related to child who is immunodeficient. All these things will be extremely important. So your medical history will give you a handle at what do I have to look at. And if there are recurrent infections, are we looking at any immunodeficiency conditions? And if there are previous admissions or psychiatric disturbances, are you looking at there are children who present, adolescent especially, who present with encephalopathies, and they will have abnormal movements, and it could be non-organic etiologies. So that also can confuse you at times. And access to any drugs and travel history also becomes important. Next slide, please. So clinical clues to etiology will be, if you have early seizures with encephalopathy within 1 to 2 days of fever, dengue is one of the most common pathology to look at in that sort of situation, followed by streptococcal and meningococcal infection. Meningococcal is not very common in our setting, but northeast states, it can be seen. If you have a biphasic neurologic illness, you'll have to think of acute encephalopathy with late restricted diffusion. That is, a child has a seizure, improved after 2-3 days, the child was in the ward, suddenly deteriorates, has flurry of seizures and deeply encephalopathic. You are looking at a condition called acute encephalopathy with late restricted diffusion. If you have isolated CNS infection, like you don't have any peripheral markers, in dengue you'll have peripheral markers, in rickettsial you'll have peripheral markers. So like that, if you don't have peripheral markers, only isolated CNS, you'll have to more likely herpes or JE. These are the usual common organisms. Next slide, please. So if the child is emaciated, it could be tubercular meningitis, HIV associated infections. Thankfully, HIV associated infections, it's become extremely rare as of now. We have not seen any in almost more than 10 years. If there is significant pallor, malaria, or intracranial bleed, if there is icterus, malaria, enteric encephalopathy, hepatic encephalopathy, if there is a skin rash, you are looking at dengue, rickettsial infections, and other viral infections. If there is a malar rash and acute encephalopathy, you are looking at SLE with CNS involvement. If there is erythema nodosum in a child with encephalopathy, they are very non-specific in nature, but you can make us think of streptococcal and tubercular infections. And eye examination gives a wealth of information. If there are retinal hemorrhages and cotton wool spots, it can be seen in malaria, retinitis in CMV. Early cranial nerve palsies are usually seen with either TBM or Bickerstaff encephalitis. So each and every clinical examination findings will point towards a particular etiology. A significant splenomegaly will be enteric, malaria, HIV, subacute bacterial endocarditis with stroke. What it is driving is as a clinician, we have a lot of responsibility to narrow down the differentials and get to this. Yes, these are the narrowed down differentials so that your list of investigations is reduced. Otherwise, there is so much of investigation we can do, it becomes a burden on the families. Next slide, please. So if there is a high temperature, it's a infection like pneumonia, septicemia, or systemic inflammatory response syndrome, and it can be cerebral cause as well. Meningitis, encephalitis, all of them can present with uh, sort of high temperatures as a part of manifestation. Other thing we should notice, with the increasing temperatures in the environment, heat strokes are also can present with acute encephalopathy. Hypothermia with encephalopathy generally is seen with severe sepsis in infancy or newborn, and barbiturate poisonings. Next slide, please. And always check the blood pressure. If hypotension, shock septicemia, intoxications. Hypertension, it could be part of raised ICP or hypertensive encephalopathy as such. Next slide, please. Yeah, and the breathing pattern is very helpful to say if it is neurogenic hyperventilation, it is diffuse cortical involvement. If there are sigh breaths, the child is taking sigh breaths, it's a medullary involvement for us. There are other patterns which are not so common. Anemia and jaundice we look for in the skin, exanthematous changes, and if you have a bruising over the scalp and mastoids, look for basal skull fracture. Bruising elsewhere in the body, you will have to look at one point insult versus multiple stage scars. If you're looking at multiple stage scars, it will start making us worry about possibility of a battered baby syndrome or non-accidental injuries. Next slide, please. So we'll skip this. Next one. So there can be various lesions in the this one SLA lesions and the Janeway lesions, which can be part of vasculitic bar SBE. Next slide. Yeah. So sometimes even the stools can give exam. This is a child who had recurrent encephalopathy, and all the investigations, CSF, MRI twice, everything came normal. And the fourth time the child got admitted with encephalopathy and ventilatory failure, the nursing staff showed this color of the stool, which was extremely unusual. And this was sent for toxicology screening and was found to have organochlorides. So somebody, there was a Munchausen by proxy, somebody in the family was poisoning this infant was being adopted into the family. So diagnosis came just from the stool examination, nothing else. Okay, so the etiologies can be very varied, and you are, as a clinician, you should have very wide range of this one options open so that you get to a final diagnosis. Next one. Yeah. So if you have a chest infection with encephalopathy, you will have to think of systemic inflammatory response syndrome, streptococcal infections, mycoplasma pneumoniae, influenza H1N1, and tubercular. Next one. And these are eye examination. Papilledema is usually seen with either synovenous thrombosis or a massive intracranial hemorrhages. Next one. Yeah. So, and this is in malaria, you can have retinal white spots, but not very common, as I said. Next one. So all of you are aware of different pupillary findings in acute encephalopathy. I'll not spend much time. Khalid is just waiting there to start his talk. Next slide, last one. Yeah. Yeah. So it's infant with acute encephalopathy. Infants, especially consanguineously married, they come with acute encephalopathy if they have hyperglycemia, hypoglycemia, metabolic acidosis, and if you have metabolic stroke like this, the basal ganglia infarcts. So you should think of metabolic strokes causing either aminoaciduria or organic aciduria. Organic aciduria is far more common to cause metabolic strokes as compared to aminoacidurias, and you'll have to screen for TMS, blood lactate, ammonia, and the urine organic acids. Next one. Yeah. So the tools for diagnosis in acute encephalopathy is the organ between the two ears. So you'll have to, your brain has to be put to work. That's the most important thing. Then you'll have your list of investigations after your history and clinical examination. Always look at your end organs. That might be, there might be a clue to the etiology in the end organ evaluation, like LFTs, renal function test, electrolytes, all those things. Neuroimaging pattern recognition, which Khalid is going to talk about now, and CSF, usual routine plus PCRs for autoimmune workup, and respiratory secretions for PCR sometimes gives a clue, like H1N1 infection, your CSF is not going to pick it up. So you have a pattern of myelitis or encephalitis, and then you send a respiratory secretions, adenoviral infections is other thing which was happening in last 6 months. So, but the diagnosis doesn't come from the CSF, it comes from the respiratory secretions. Stool examination can give adenovirus or rotavirus, those kind of infections can be picked up there. Autoimmune parallels, toxicology screen, metabolic workup in infants less than 2 years of age, especially. So, these are the various things you'll have to look at. And today we are going to focus on what Khalid is going to show us about the importance of radiology in the acute encephalopathy. Over to you, Khalid. Thank you. Thank you, Ankit.
Thank you, sir. Thank you for enlightening us with the clinical perspectives of acute encephalopathy in children. It was great to know about the various clinical signs and the symptoms that could help us narrow down the wide range of differentials. I now request Dr. Khalid to take us through the various imaging findings of acute encephalopathy.
Thank you, Dr. Ankit, for your kind introduction, and thank you, Lokesh sir, for accepting our invitation. Thank you, Lokesh sir, for accepting our invitation. I'll be starting my seminar now. So the topic is pediatric acute encephalitis, and I'll try to cover it in next half an hour or so. So as discussed, acute encephalitis in children is very vast topic in itself. So we won't be doing any justice by covering it in half an hour, but I will try to include the most important imaging aspects which we encounter in day to day in while in a patient who presents with acute encephalitis. So this is the structure of my talk. First, we'll talk with basics. I think I can skip through the disease definitions as Lokesh sir has covered the most of the things. So my next topic would be the various etiologies which we can expect in acute encephalitis, and finally the imaging aspects and conclusions. So we'll directly start with the multiple etiological agents with acute encephalitis syndrome. So I tried to classify them into infectious, para-infectious, inflammatory, autoimmune, and miscellaneous agents. So bunch of the acute encephalitis with known cause are due to the infectious agents, and para-infectious are the next most common cause. Para-infectious agents include acute necrotizing encephalitis or acute disseminated encephalomyelitis, and inflammatory demyelinating diseases like Mohd can also have similar clinical picture like acute encephalitis, and various autoimmune diseases with antibodies associated against the neural tissues can also have similar clinical presentation with acute encephalitis, and other rarer conditions like HLH, vasculitis, and metabolic conditions can also cause acute encephalitis clinically. They need to be differentiated from the more common infectious or para-infectious agents for better prognostication and treatment. So this is a study carried out with retrospective analysis of 108 cases with acute encephalitis by NIMHANS. So they found among the known causes of acute encephalitis, arboviral infections were the most common cause, and among the arboviral, dengue was the most common of them. And this is a chart published in Annals of Neuroscience. We can appreciate the distribution of Japanese encephalitis along the Ganges plains. It is most likely to the fact that water birds act as reservoirs for Japanese encephalitis, which is spread by the Culex mosquitoes. And recently we had a few epidemics of acute encephalitis with Nipah virus and Nipah virus in 2018, and with Lychee virus in 2014. So the Lychee virus turned out to be a toxin-induced encephalopathy, which is associated with consumption of the unripe fruits, which contained a toxin which led to hypoglycemia and which further caused the encephalopathy in children. So coming back to specific encephalitis. In India, acute pediatric encephalitis is considered synonymous with Japanese encephalitis, and it is most common in monsoon seasons, especially from July to October. And imaging features of Japanese encephalitis include typically the involvement of the brainstem with the thalamus, and in the brainstem, the substantia nigra is more typically involved. So here in this case of a 20-year-old who presented with clinically with encephalitis features, we can appreciate swelling and hyperintensity in bilateral thalami with more involvement of the right side of thalamus, and corpus striatum involvement is the second most common finding we see in cases of Japanese encephalitis, and in this case there was involvement of peri-insular regions as well. And diffusion weighted imaging in most of the cases would show a restriction with hypointensity on ADC. And on literature, we found association of Japanese encephalitis with the neurocysticercosis. As for Japanese encephalitis, pig acts as a amplifier host, and in cysticercosis, pig acts as the intermediate host. And there was association with cysticercus granulomas occurring in patients who are suffering with Japanese encephalitis. As in this case, we can appreciate cysticercus granuloma in the left frontal region. Other than that, there were confluent hyperintensities in bilateral thalami and left corpus striatum. And this is the post-contrast axial T1 weighted imaging, which showed ring enhancement. And further establishing this association, there was more extensive involvement of the ipsilateral cerebral hemisphere with Japanese encephalitis when there is a focus of cysticercus granuloma in the ipsilateral lobe. Herpes simplex encephalitis is way more common in Western countries. And on imaging, we can appreciate bilateral, relatively asymmetric involvement of the medial temporal lobes along with basifrontal and cingulate gyral regions. And these are associated with diffusion restriction in most of the cases. And SWA would show blooming focus, which is consistent with pathology of hemorrhagic necrosis, which can be seen with herpes encephalitis. And further, these can progress to frank cystic encephalomalacia. This is again another case of herpes meningoencephalitis. In this coronal T1 weighted image, we can appreciate the features of meningoencephalitis with enhancement of meninges and cortex. And MR spectroscopy would show elevated lipid lactate associated with necrosis or anaerobic metabolism. And there was associated elevated glutamate peak also at 2.5 ppm. Coming to varicella zoster viral infection, which is also known as chickenpox or shingles. So patients with varicella zoster virus can present with stroke or cerebellar ataxias, or they can have herpes zoster ophthalmicus. This is patient with encephalitis features. On the axial T2 weighted images, we can appreciate there is swelling and hyperintensity involving posterior aspect of the cerebellum. And this sagittal T1 weighted imaging shows compression of the aqueduct with further upstream hydrocephalus involving bilateral lateral ventricle and third ventricle. Another presentation of herpes zoster encephalitis is with stroke-like symptoms. In this patient with left-sided paralysis, we can appreciate there is a patchy focus of flare hyperintensity in right capsuloganglionic region. And on top MR angio, we can appreciate the narrowing of distal ICA and right proximal MCA and proximal ACA. Other differentials for similar imaging features would be dissection in children, but with the CSF analysis and further history, we can differentiate between the dissection and herpes zoster vasculitis. Next, coming to non-polio enterovirus, they usually spread by fecal-oral route. They can be associated with pharyngitis, gastroenteritis. They can also cause meningoencephalitis to acute facet paralysis like polioviruses. They are most known to cause rhomboencephalitis pattern of infection in the brain. So in this sagittal T1 weighted imaging, we can appreciate patchy region of hypointensity in caudal aspect of pons, which is extending into rostral aspect of medulla. This axial imaging shows the same findings. Influenza virus, it usually occurs as a seasonal upper respiratory tract infection, which can progress to encephalopathy. So, and this influenza infection is more severe in syndromic child. As in this Down syndrome child who presented with encephalitis feature, you can appreciate confluent regions of hyperintensity on both on T2 weighted imaging with corresponding hypointensity on T1 weighted imaging. And on SWA, we can appreciate patchy and confluent foci of blooming, consistent with pathology of vasculitis, which can be seen with direct infection with influenza encephalitis, or this can also represent para-infectious acute hemorrhagic leukoencephalitis pattern, which can again be seen with influenza encephalitis. Dengue encephalopathy is way more common than direct dengue encephalitis. So the dreaded complication of dengue infection is dengue hemorrhagic feature, which dengue hemorrhagic syndrome, which can give rise to secondary involvement of the CNS with hypovolemia, hypoxia, or shock. So, but in few cases of recognized dengue encephalitis, two patterns were identified. This reverse mustache pattern is associated with peripheral rim of diffusion restriction in the pons, which is associated with hyperintensity in corresponding region on flare and hypointensity on ADC. Another pattern which is considered specific for dengue encephalitis will be bilateral symmetric involvement of the thalamus, which is mimicking a neck pattern of encephalitis. This is labeled as double donut sign. Chikungunya encephalitis, patients infected with chikungunya are more symptomatic than the dengue infection. So it is also like arboviral disease, which is spread by Aedes aegypti, and it is caused by alpha virus. On imaging in patient with chikungunya encephalitis, we can appreciate patchy foci of flare hyperintensity with the diffusion restriction as seen in this case, and corresponding region may show punctate foci of enhancement as in this T1 post-contrast image. So major imaging differential for this pattern of involvement will be fat embolism or diffuse axonal injury or acute hemorrhagic leukoencephalitis. Dengue myelitis can also present as a GBS pattern with enhancement of the nerve roots. Another pattern associated with chikungunya encephalitis will be hyperintensity along peripheral aspect of the spinal cord. So this pattern is not seen in any other condition. So this is considered pathognomic for chikungunya myelitis. Rabies encephalitis is a fatal disease. It presents in two forms with encephalitic or paralytic form. So in encephalitic or furious form of rabies, the diagnosis is straightforward and imaging is rarely needed. So in furious form, rabies encephalitis usually presents with hydrophobia with hypersalivation. Whereas paralytic form, it can present with acute flaccid paralysis. So like in this 20-year-old patient who presented with left upper limb weakness, which progressed to quadriparesis. So clinically, GBS was suspected, and the MRI imaging was done as there was progression to acute flaccid paralysis. So on this imaging, we can appreciate this patchy hyperintensity with swelling involving the right frontal lobe with confluent hyperintensities involving bilateral thalami, hypothalamus, right corpus striatum, and image brainstem and superior cerebellum. So imaging differentials for similar involvement will be other encephalitis, but in other encephalitis, diffusion weighted imaging can show restriction, but rabies diffusion weighted imaging is known to show shine through effect without restriction. This can help to differentiate from other encephalitis. The incidence of bacterial meningoencephalitis has decreased in recent years due to regular vaccinations with Haemophilus influenza type B and pneumococcus. In this 3-month-old child who presented clinically with encephalitis features, this axial T1 weighted imaging, we can appreciate there is debris fluid level in bilateral occipital regions with heterogeneous signal intensity in bilateral frontal regions. And T2 weighted imaging also showed similar features of diffuse edema in the rest of the brain with heterogeneous hyperintensity in frontal region. And the post-contrast imaging showed patchy enhancement in the periphery of the necrosis, which was appreciated on plain T1 weighted imaging. Other than that, there was enhancement along the ependymal lining, which suggests some ventriculitis pattern. And this imaging was done a few weeks after presentation with acute encephalitis. So ventriculitis has progressed to a periventricular necrotic pattern with periventricular frank encephalomalacia communicating with bilateral lateral ventricle. We can also appreciate a few septations in the caudothalamic groove regions. And further, there was debris fluid level in bilateral occipital regions. Patients with ventriculitis are known to progress to periventricular necrosis or periventricular gliosis secondary to obstruction of subependymal veins or due to direct cytotoxic injury with bacteria or acute inflammation secondary to the bacterial infection. Other complications of bacterial meningoencephalitis include subdural collections. As in this case, we can appreciate the cortical veins are more close to the gray matter, so suggesting there is increase in subdural space bilaterally. In this axial flare image without contrast, we can appreciate the right subdural collection is showing marked hyperintensity, and whereas the left subdural collection is signal intensity is almost similar to the CSF signal intensity. Other than that, we can appreciate sulcal hyperintensity on this flare imaging. So this sulcal hyperintensity would suggest meningitis changes. Other differential for such sulcal hyperintensity include if the child is under general anesthesia or use of fentanyl can also cause such sulcal hyperintensity. So this is ADC map of same case showing restricted diffusion along the right cerebral convexity. However, other subdural collections are showing T2 shine through. So this would suggest that these are subdural hygromas with subdural empyema in right cerebral convexity. This post-contrast imaging shows similar features of leptomeningeal enhancement with subdural empyema and subdural hygromas. Other complication of streptococcal meningitis would be acute infarcts. So in this axial T2 weighted imaging, we can appreciate patchy scattered foci of well-defined heterogeneous hyperintensities, which are extending into periventricular regions. So acute infarct in meningoencephalitis occurs due to exudates extending along the perivascular spaces. So we see infarcts mostly in the perforator territories and in periventricular regions. So this is ADC map of the same case showing significant reduced restricted diffusion in bilateral capsuloganglionic thalamic periventricular regions. And MR spectroscopy is non-specific with elevated lipid lactate, decreased NAA, and elevated glutamate peaks. Other complication of bacterial meningoencephalitis is venous cerebral ischemia or infarction. So they usually present with parasagittal regions of edema, as in this case, we can appreciate subcortical edema on T2 weighted imaging with ADC map was showing subtle restricted diffusion along the cortex. Susceptibility weighted imaging in the same case showed curvilinear blooming hypointensities. This would correspond with thrombosed vessels, and few punctate foci of blooming hypointensities were also seen in the peripheral aspect. And this post-contrast T1 weighted imaging shows filling defect in the veins. And this post-contrast T1 sagittal image showed filling defect in the transverse veins. Tuberculous meningitis is the most common extrapulmonary manifestation of tuberculosis. So, contrary to the cerebral convexity meningitis, which we see in pyogenic infection, basal exudates are way more common in tubercular meningitis. We can also see enhancing granulomas in right central semi-ovale, and T2 hypointense foci in the central semi-ovale. This T2 hypointensity is considered characteristic for tuberculomas, and there could be extension of meningitis along the spinal cord, as in this case there was a focal tuberculoma in the lower cervical region with the compression of cervical spinal cord. So, and this image shows better evaluation of meningeal enhancement on delayed post-contrast images. So this image on left side is immediate post-contrast, and image on right side is delayed post-contrast after 5 minutes of injection of gadolinium. So in this we can appreciate enhancement to a better extent. So delayed images would definitely help in evaluation of meningitis. And this is heavily T2 weighted drive sequence, which shows thin septations secondary to exudates in preponderant systems, which are common with tuberculous meningitis. Acute necrotizing encephalitis is a para-infectious disease with typical tegmentothalamic involvement, as seen in this CT study, which shows symmetric hypoattenuation in bilateral thalami. And then MRI imaging, we can appreciate swelling and hyperintensity along the pontine tegmentum, which further involvement of the deep cerebellar white matter and cerebral white matter and dorsal aspect of the corpus striatum, as well, in addition to involvement of the thalamus. So acute necrotizing encephalitis is known to undergo cavitation very early with T2 shine through on ADC map. And on MR spectroscopy, we can see elevation of lactate peak due to necrosis or lysis of the cells with decreased NA. And when a patient is having recurrent episodes of acute necrotizing encephalitis, or if the same family members are having episodes of acute necrotizing encephalitis, we should look for mutation in RAMBP2 gene, which is the autosomal dominant disease, and patients with these mutations are prone to acute necrotizing encephalitis. ADEM and acute hemorrhagic leukoencephalitis is another parainfectious disease, but it is pathologically different from ANEC. So ADEM is basically an inflammatory demyelinating disease, and it presents with confluent white matter hyperintensities with no significant adjacent mass effect. And these hyperintensities were described as cotton ball or cotton wool opacities, and there is predilection for perivenular involvement. So in unlike MS, MS usually presents with punched out, well-defined effects, but ADEM lesions can have ill-defined lobulated margins, as seen in this case, and involvement of cortex is less likely in cases of ADEM. So enhancement in ADEM is variable. So, but in this case, there was intense enhancement with restricted diffusion. This is another case of ADEM showing perivenular propensity of the disease, and there was further progression of the disease with more significant hyperintensities on T2 and enhancement on post-contrast. Acute hemorrhagic leukoencephalitis is considered a fulminant manifestation of ADEM, and it can present with macro or micro hemorrhages. So this is another case of acute hemorrhagic leukoencephalitis with presenting with punctate microhemorrhages. So imaging differentials for this would be diffuse axonal injury or fat embolism, and even chikungunya encephalitis also can present similarly. And Mohd is a autoimmune disease associated with antibodies against MOG antibodies, which are MOG antigens, which are located at the outer aspects of the myelin sheath or on the oligodendrocytes. So unlike NMOSD, which is associated with antibodies against food process of the astrocytes, which are seen in the food process of astrocytes. And this is the clinical presentation of Mohd. So in pediatrics, Mohd presents mostly with ADEM features, whereas in adults it can have optic neuritis or myelitis as more frequent involvement when compared to children. So Mohd, the imaging features could be similar to ADEM with the confluent white matter hyperintensities in both infratentorial and supratentorial regions. However, the cortical involvement is more frequent in Mohd when compared with the ADEM. And Mohd optic neuritis is usually long segment with perioptic thickening, perioptic enhancement, and perioptic fat stranding. In case of NMOSD, there will be optic chiasmatic involvement in most of the cases, whereas Mohd would usually spare optic chiasm. And the Mohd myelitis would usually prefer conus involvement, and H sign has been described on axial images in case of Mohd myelitis. There can be associated with leptomeningeal enhancement, and in some cases of Mohd, parenchymal enhancement can also be seen. And other than the usual manifestations of optic neuritis, myelitis, and ADEM, Mohd can also present with meningocortical manifestations. So this patient had positive MOG antibodies in serum and CSF, and this this pre-contrast axial flare imaging, we can appreciate flare circle hyperintensities with cortical hyperintensity and subcortical hypointensity. And there was a subtle leptomeningeal enhancement on post-contrast imaging as well. So, and the lesions were better appreciated on T2 weighted flare imaging, and T2 weighted imaging was unremarkable. And there was cortical restriction on DWA imaging. So, this pattern of involvement in Mohd is termed flames, which translates to flare hyperintense lesions associated with the MOG encephalitis with seizures. And other manifestation of Mohds was with only leptomeningeal involvement without cortical involvement. So this is labeled as fuel, which translates to flare variable unilateral enhancement of the leptomeninges. So in this patient with positive serology for MOG antibodies, we can appreciate there is associated optic neuritis as well. So in any case with aseptic meningitis with optic neuritis or myelitis, which are pointing towards Mohd, we can suspect the possibility of fuel with as these conditions usually are very much responsive to steroids. This is another similar case with meningeal enhancement and optic neuritis with positive serology for MOG antibodies. Autoimmune encephalitis, it is secondary to anti-neuronal antibodies. So this is the prototypical autoimmune encephalitis, which can be seen in paraneoplastic conditions. In women, NMDA encephalitis is mostly associated with orient teratomas, which cause a stimulation of the immune system to neuronal antigens, which further leads to encephalitis. So this is the typical pattern of NMD encephalitis, and with bilateral symmetric involvement of the limbic system. And these patients usually present with psychiatric symptoms. Other imaging differential for the similar pattern of involvement would be herpes encephalitis, but herpes will usually show restricted diffusion, and we can further see blooming in corresponding regions on SWA imaging. This is a follow-up of the same case showing features of mesial temporal sclerosis with adjacent volume loss. Other autoimmune disorder which is associated with specific imaging pattern is anti-GFAP astrocytopathy. So GFAP is a cytosolic protein in astrocyte. So it is associated with typical imaging patterns of radial bands of vertical enhancement in bilateral periventricular regions. So if you find such imaging appearance, a radiologist must suggest for evaluation of GFAP antibodies in CSF and serum. And other than the most typical features seen on post contrast, T2 flare would show confluent hyperintensities in white matter with minimal hyperintensity on DWA imaging, and SWA is unremarkable. It's a similar case of anti-GFAP astropathy with involvement of perivascular enhancement on post contrast imaging and confluent regions of hyperintensity on flare. And GFAP astrocytopathy can also present with myelitis with cord swelling and confluent hyperintensity. And on post contrast, we can appreciate curvilinear and punctate foci of enhancement. HLH is a rare cause of encephalitis. However, it must be differentiated from other more common causes. So, MRI is not considered a diagnostic criteria for HLH, but when patient presents with confluent white matter hyperintensities and clinically he is having hepatosplenomegaly with bicytopenia or pancytopenia, we should consider the possibility of HLH. So in this patient with the known familial HLH, we see confluent white matter hyperintensities which are similar to ADEM, but there is more cortical involvement. And on follow-up, there was volume loss with a decrease in size of hyperintensities. And HLH also favors the brainstem and cerebellar involvement when compared to typical ADEM or other infectious conditions. HLH can also present as the Clipper's morphology with punctate and curvilinear foci of enhancement. So this is the post-contrast flare image showing significant leptomeningeal enhancement with patchy foci of hyperintensity in bilateral thalami in a case of HLH. And on follow-up, this is post-contrast flare, which shows volume loss related to the previous imaging, and there was significant decrease in amount of leptomeningeal enhancement, and there was mild reduction in size of white matter and thalamic hyperintensities as well. HLH can also present as acute cerebellitis. So these patients with acute cerebellitis later go on to have imaging findings in supratentorial regions as well, as in this case with who presented initially with cerebellitis and hydrocephalus involving bilateral lateral ventricles and third ventricle. On later imaging, it shows the confluent white matter hyperintensities and volume loss in supratentorial regions as well. Next, coming to FIRES. FIRES is a clinical diagnosis. So this is the temporal evolution of a patient with FIRES. So when the patient presents with seizures, fever had usually resolved. So there will be increasing frequency of seizures in patient with FIRES, which progress to status epilepticus, and in much chronic stages, the seizures will decrease in frequency, will become refractory, and there might be cognitive deficits or behavioral disorders. And in FIRES, the imaging in initial stages is usually normal. And the imaging in FIRES is usually done to rule out structural abnormalities. So changes on imaging in FIRES are usually seen few days to few weeks into illness. These are likely secondary to excitotoxicity, secondary to frequent seizures. So we can appreciate some diffusion restriction in the mesial temporal regions, thalamus, corpus striatum, and perinsular regions. This is a diffusion weighted imaging map which shows reduced diffusivity along the cortex and bilateral thalami. And literature showed bilateral perinsular sign as a specific feature for fires. So in a few days to few weeks into the illness, we can see periventricular hyperintensity with restriction in case of patient with suspected fires. Next, coming to other conditions with acute encephalopathy with biphasic seizures and restricted diffusion. So unlike fires, the patients with acute encephalopathy with restricted diffusion present with febrile seizures, and usually it is followed by normal cognition and asymptomatic period for few days, and which is again followed by cluster of complex partial seizures. And imaging in ASD will be normal initially. However, after few days, it can show symmetric regions of frontal or frontoparietal restriction, which is predominantly involve subcortical U fibers. So this imaging pattern in ASD is considered pathognomic, and ASD is a clinical radiological diagnosis, unlike fires, which is only clinical diagnosis. And in most of the cases with biphasic seizures with restricted diffusion, there was sparing of perirolandic regions. There was another condition with same pattern with more florid involvement, which is labeled as acute leukoencephalopathy with restricted diffusion. In this, the imaging showed subcortical U fiber involvement with no sparing of the perirolandic regions. So this is another case with toxin-induced acute leukoencephalopathy with restricted diffusion, which showed typical imaging features of subcortical U fiber involvement. This is the case of snake bite. On day 8, the imaging was done, which showed confluent white matter hyperintensity with restricted diffusion, predominantly in parietal regions, with involvement of the corpus callosum. So this patient was treated as acute leukoencephalopathy restricted diffusion, and on follow-up on day 20, there was volume loss in supratentorial cerebral hemispheres with residual hyperintensity in bilateral corpus striatum. So finally, after seeing all the imaging findings in encephalitis, so few important pathognomic features which can be in which imaging helps in identifying particular disease etiology. So in case of Japanese encephalitis, in almost all cases, there will be involvement of thalamus and substantia nigra with involvement of corpus striatum in 2/3 of the cases. In herpes encephalitis, there will be involvement of bilateral symmetric mesial temporal regions, basic frontal region, and cingulate gyrus with associated diffusion restriction and blooming hypointensity. In case of ANEC, there will be tegmentothalamic involvement with variable involvement of the putamina and cerebral and cerebellar white matter regions. And in case of chikungunya myelitis, the pathognomic features of peripheral T2 hyperintensity, which are likened to the glass seal sign. And we can diagnose MOGAD when there is long segment involvement of optic nerve with optic nerve sheath involvement and no involvement of the optic chiasm. And MOGAD favors conus with H morphology on axial T2 images. And to consider possibility of meningocortical involvement of MOGAD when there is aseptic meningitis on imaging with typical features of optic neuritis or myelitis. And GFAP astrocytopathy will have specific features on imaging with the periventricular radial enhancement as seen in this post-contrast imaging. And acute encephalopathy with the biphasic seizures restricted diffusion is the clinical radiological diagnosis which is associated with the typical imaging pattern. And in conclusion, acute encephalitis is associated with wide range of causal agents, and there will usually a very small window period between diagnosis and treatment. Geographic location, seasonal variation, and history play a significant role. Neuroimaging can help in few conditions, and it can help to differentiate in mimickers like tumors or infarcts. Or diffusion-weighted imaging is more sensitive, especially in early neonatal or late infantile periods where T2-weighted imaging is hyperintense throughout. Diffusion-weighted imaging can show restriction, suggesting early encephalitis changes. Serial neuroimaging also allows monitoring of the disease progression and assesses response to therapy. Thank you.
Thank you, Dr. Khalid, for this extensive review of various etiological factors for acute encephalitis and their imaging presentations. We'll just wait for a few seconds for the questions from the audience. In the meanwhile, if we have Dr. Lokesh Lingappa sir, he could just give his few comments on the same.
Yeah, yeah. Thank you. I think that was great. Exhaustive review. The challenges in this situation is one is getting the scan done itself. When it's acutely unwell child who is intubated, hemodynamically unstable, so getting an MRI done sometimes becomes a challenge. So initial point of call might be a CT scan, and only when stabilized we can shift them for a MRI. And sometimes they are not very sensitive for demyelinating abnormalities. So you might have to repeat a scan. The initial scan is normal. Even a MRI might be normal in first 1 or 2 days of illness in some of these conditions. And later on a day 5 to day 7 scan might show abnormality. That is one thing the clinician should be aware of, that if your encephalopathy is still there, seizures are still persisting, initial MRI is normal, you probably have to repeat a scan between day 5 to day 7. We have a thesis which demonstrated this kind of changes, more so towards a demyelinating pathologies, which show all the clinical manifestations come early, the neurology, the MRI changes come a little bit later. So we need to be aware of that caveat. And like ALERD, which Dr. Khalid showed the MRI findings, so your initial MRI there will be normal again or show minor changes, and there will be florid changes in the repeat MRI when there is a second reversing. So these are the scenarios where as a pediatrician or a clinician should take a call as to when to repeat the scans. And as it is always a two-way loop, so it is better to speak to the radiologist. See, this is a child, these are the clinical features, I'm trying to look for these etiologies. So then it is the radiologists are going to supervise much more closely and look for that finer details, and do any extra sequences required, ask for contrast at that point in time. Sometimes what happens is the acute child is shifted back, and then the radiologist will have a look at it and say, oh, this child needs contrast, you can't shift the child back again. So all these things has to be finely coordinated so that the patient care is taken with a great care, and it will be more smoother process. It always happens with a two-way interaction. Before the patient is shifted, the radiologist should be aware of the child, and that way it works better. I think everybody would agree, isn't it, Dr. Ankit? And
Yes, sir. I
yeah,
definitely second that, sir. And
yeah,
especially with the advances in the imaging that we now have and the number of
yeah,
imaging options that we now have, like especially the
yeah,
black blood imaging or post contrast
yeah,
flare imaging, a
yeah,
radiologist supervising the scan would always add to the knowledge and do better
yeah,
patient service at the end of the day.
yeah,
Just a
absolutely.
follow-up question, sir. You just mentioned briefly about the ALERD.
Yeah,
Is the pathophysiology quite clear, or still we are trying to understand the pathomechanisms of
it
the?
looks, yeah, it looks like a inflammatory cytokine storm kind of thing, wherein there is a significant inflammation of the both white matter and gray matter, and there is a severe restricted diffusion predominantly in the white matter, but the edema is shown both in gray and white matter. And it's a reasonably common entity, and it can cause a focal abnormality or diffuse abnormality. The unfortunate thing with this condition is they have very severe long term cognitive deficits and refractory epilepsy. So even though they survive, that is the long term effect of this ALERD. We treat with a lot of immunomodulation, steroids, IVIG, and other things. Cyclosporins have been tried, but despite all the therapies, cognitive issues are the long term issue with this.
So does it
Yes.
depend on the significance of the initial insult, initial febrile seizures? If they are more severe, the next
not
complex
not
portion.
not necessarily, not necessarily. Actually, there is no correlation between the initial disease severity. Somebody who had a febrile illness, febrile seizure for 10 minutes is on the ward, and then it's, I think, basically the your HLA phenotyping, how you respond to given infection, what is that going to act on the brain. That's how it is boiling down to, rather than the severity of initial insult.
Thank you, sir. I
Thank you.
would just request you to answer one more question, sir. That is for the good of the audience. Like, Nowadays, we see that people are quite afraid of eating lychees because of the scare of lychee encephalitis, presuming that this is secondary to an infective agent. Though
Yeah.
Dr. Khalid briefly mentioned about the etiology, if you could just elucidate that for the
Yeah,
to the
yeah.
audience.
So this investigation by the team, including people from the CMC Velo, so wherein they found that these were the children from the laborer group, migrant laborer group, where they were having this when they were hypoglycemic early in the morning without proper food, wherein that triggered the significant hypoglycemia. Whereas if you are having lychee as a top up on after your regular food and this one in a moderate amount, it is not going to cause any encephalopathy. So it was predominantly hypoglycemic in a group of children who used to pick it up in the early morning hours and have it to fill their stomach with just lychees. That is a situation where it triggered off the acute encephalopathy secondary to hypoglycemic insult.
Yes, sir. Thank you, sir. Thank you for your valuable time. Thank you, Dr. Khalid, for the extensive illustration of various pathologies.
Yeah, I had to speak. I had to skip few common etiologies like scrub typhus, Lyme's, and some Beckett's brainstem encephalitis and GPS spectrum because of want of time. But I tried to cover almost all the important things. So
Yeah, thank you for your session. I would now close the session. Thank you, all the attendees, for attending the session. Have a good day.
thank you.